Hello, good evening, everybody. I'm Dr. Sivarajan Thandeswaran, stroke and neurovascular consultant at Kaveri Hospital. So it's a great opportunity to interact with all our doctors across Chennai and beyond on neurovascular complications in COVID and post-COVID. So we all are in the midst of this nasty pandemic, and yes, quite a lot of us have gone through tough situations, have possibly lost close friends and family, and we are facing a lot of difficulties with the loss of a lot of our patients and so on. But as the pandemic evolves, the knowledge behind COVID is also rapidly evolving, and it's a good opportunity to share what we have read through amongst the big journals and also a personal experience among treating COVID patients. So, in my first slide, I've got a picture, electron microscope picture of the coronavirus with all the spike proteins with the red arrows showing them. And in the picture B, it just shows the glycoprotein makeup of the spike protein. The composition, the red is the S2, and the green is the RBD, which is the receptor binding domain that sits on the ACE2 receptor on the cells, which through which they gain entry into our cells. Angiotensin converting enzyme is pretty abundant in all our cells seen across our body, including vascular endothelium and neuronal cells, and so on. So as they enter the cells, they replicate very rapidly, and using our own DNA and our own genetic material, and it breaks down our cells. In the process, our body tries to generate immune response, and in a very few unfortunate amongst us, we generate a very robust and deleterious immune response, which starts breaking down our own protective mechanisms. So the viremia can lead to inflammation, which in turn can trigger coagulopathy, and it can also directly attack the endothelial cells, causing vasculitis. And the combination of these can cause thrombosis and thromboembolism. And a subset of them can go on to develop strokes. Some of them may go on to develop large artery thrombus in the aorta, in the iliac vessels or brachial vessels, leading to limb ischemia. We have also seen patients having mesenteric artery thrombus leading on to bowel ischemia and so on. So yes, there is a very busy slide. It just shows how the virus can gain entry into our neurovascular unit. So our neurovascular unit is a very tightly guarded cell and organ in our body, and it is protected by the blood-brain barrier, astrocyte ends, and also the tight cell lines across the pericytes and also the microglia. So what happens in SARS-CoV-2 is as soon as they enter the enterocytes or the alveolar type 2 cells, they start generating our innate immune mechanisms, and it starts a milieu of interleukins, which in turn trigger increased neutrophil, macrophage, monocyte, and T cell response, and which in turn can stimulate a lot of tumor necrosis factor alpha, macrophage function, and T cell regulatory mechanisms, which lead to hyperinflammation mediated injuries. When they attack the endothelial vessels, it can cause endotheliitis, which in turn can cause diffuse permeability of the cell lines, which again, after the injury to the cell wall, causes coagulation cascade activation and multi-organ dysfunction. In the neurovascular unit, the impaired endothelial autoregulation, the endothelial membranes in our brain cells have a direct link to our adrenal system and also the neurocardiogenic system, which regulates the blood flow, blood pressure, and so on. It causes a disruption of that autoregulatory mechanism, leading to vasospasms inside the brain vessels, and the blood-brain barrier disruption can lead on to increased immune activation with the microglia and metalloproteinases, Hyperperfusion due to vasospasm can also lead on to small ischemic strokes and also large artery strokes. Neuroinflammation is again another area where a lot of post-COVID patients may go on to develop a lot of post-inflammatory conditions like autoimmune inflammatory uh, conditions that we routinely see in routine practice. So, like any like post herpes simplex virus, we see high incidence of NMD, etc., encephalitis. Same way, post-COVID encephalitis is also a big reality. So, broadly speaking, neurological manifestations can be divided into central and peripheral. The central, often majority of the time, it may be simple headache, dizziness, or impaired consciousness or confusion. Often we have come across patients saying they have a little bit of brain fogging. They can't think straight. They have to struggle to recall names and the dates and so on. In a severe scenarios, it may go on to develop encephalopathy or delirium. Seizures is also picked up quite a lot. Syncope and strokes, which I will talk in more detail as we go on. Encephalitis, myelitis, optic neuritis, and again, post-infectious autoimmunity is a big area. Um, Again, in milder patients, we may see anosmia, dysgeusia, cranial nerve palsies, facial nerve palsies, ulnar median nerve palsies, foot drop. Guillain-Barré syndrome, we have seen at least 2 patients in the last couple of months. Myasthenic or myocytic like myositis like muscle injuries also seen in a increasing numbers. So the pathophysiology behind the strokes thought to be due to vasculitis due to endothelial injury, which in turn triggers hyperimmune situation leading to hypercoagulability and microvascular thrombosis. Uh, Cytokine storm is again an independent risk factor for stroke due to its own deleterious effects. The viremia can attack the myocardial cells directly and cause myositis, cardiomyopathy, and arrhythmias, which in turn can lead on to cardioembolic phenomena leading to strokes. Systemic hypoxia on its own can lead on to uh, large territory strokes, encephalopathy, and so on. Fresh DVT is picked up in very big numbers in a lot of studies in France and UK. And in one of the studies, they picked up almost near to 90% of IC patients were noted to have deep vein thrombosis. And we all know that the incidence of PFOs are pretty high in general population. And in those, we often think of cryptogenic strokes during COVID time, maybe due to paradoxical embolism from the right to left. So we do come across CNS complications even without pulmonary complaints. Right from the beginning, pulmonary complications has been the main focus, but there are patients who come without any lung involvements and with direct CNS involvement. Large artery strokes are often seen post-discharge, and that's also again seen in very young patients in their 40s to 50s. Large artery strokes are not very common in this age, and COVID-19 has got direct mechanisms that leads on to large vessel thrombus formation. And these viral particles can directly infect the brain parenchyma and cause brain encephalitis. Um, and hyperinflammation provoke parainfectious autoimmunity as we discussed earlier. So how does a virus enter the neural cells? There is enough literature to show that the previous SARS virus, SARS-CoV-1, has been shown to cause neuroinvasiveness, and the same is being extrapolated to the SARS-CoV-2. And in multiple centers, it has been detected in the CSF in those with encephalitis. And the presence of virus has been confirmed in neural and capillary endothelial cells in the brain of COVID-19 patients on autopsy. The routes of entry may be due through retrograde axonal transport via nasal cavity through the cribriform plate. That's when patients develop anosmia and so on. It can be hematogenous, spread by infecting the blood-brain barrier, endothelial cells, blood sears of barrier epithelial cells, or using the inflammatory cells as a decoy. They enter the inflammatory cells, and the inflammatory cells enter the blood-brain barrier to protect us, and they can get in and spread into our neural cells. And we do know that ACE2 receptors are abundant in CNS endothelial cells, microglia, and astrocytes. So endothelial, so apart from direct neural entry, endothelial dysfunction and hypercoagulability are the other two common serious mechanisms through which strokes can happen. So endothelial dysfunction is just briefly touch on. ACE2 receptors are expressed in cerebrovascular endothelial cells that regulate the sympathoadrenal system, vascular autoregulation, cerebral blood flow. The virus binding to CNS ACE2 receptors can lead to disruption of its autoregulatory function, leading to blood pressure surges and even vessel wall rupture, which can lead on to subarachnoid hemorrhages, intraventricular hemorrhages when they affect the choroid plexus. We have, as I said, come across quite a lot of large artery strokes, and these patients are often found to have associated poorly controlled diabetes, hypertension, and coronary artery disease. So that's a very key point to note that those who have poorly controlled diabetes, hypertension should take it very seriously and try and control it promptly. With multiple tiny vascular injury, we do see punctate infarcts in multiple vascular territories. There are case reports of crest-like phenomenon, so posterior reversible encephalopathy syndrome, where we do see edematous posterior part of our brain, occipital parietal lobes, with white matter changes. There are changes, especially the neurovascular changes, the cranial nerve changes are commonly seen because of our brain's architecture. There's a lot of circulatory changes that happen in the brainstem and basal systems. So it leads on to multiple cranial nerve involvements. So coming to coagulopathy, I'm sure Professor Shekhar would be talking in depth with coagulopathy and endothelial injury. I just want to briefly mention D-dimer fibrin FDPs elevated in patients with COVID-19, and the numbers are more higher in more sicker patients, whereas antithrombin and PT activity are comparatively lower compared to healthy adults. So there are quite a lot of reports of transient antiphospholipid antibodies being detected in patients with COVID, especially with positive beta-2 glycoprotein IgA and IgG antibodies, but negative lupus anticoagulants. So they are not routine antiphospholipid patients, but they have a transient antiphospholipid syndrome due to direct COVID-19's effects. Sepsis and subsequent DIC can be a potential reason for COVID-related stroke and thrombosis. Monocyte and endothelial cell activation leading to cytokine release can result in DIC. Free thrombin circulation without full control by natural anticoagulants can both activate platelets and cause fibrinolysis, leading on to significant thromboembolic phenomenon. So the direct neural inflammation can lead on to hyperinflammation in the neural cells. And apart from the stroke, routine stroke presentations, we do have patients having slightly out-of-the-box clinical additional scenarios where they appear more delirious, have a lot of psychotic features, and some of them may progress to deep coma, which is not fully explained by ongoing seizure activity like partial status or non-convulsive status or prolonged post-ictal status. And it doesn't also fit in with metabolic abnormalities or medications effects. So there is a ongoing inflammation directly in the neural cells due to COVID, along with the stroke motor sensory effects. And these symptoms are often concurrent with a rapid rise in the CRP, ferritin, and interleukins. So keeping a close watch on them can give us a trend of when the patient is going to get worse and when they would get better. CSF analysis often is normal. Mildly elevated protein level is probably what is mostly seen with very little pleocytosis. That probably is concurrent with the lymphocytopenia that is noticed in most COVID patients, which is caused by lymphocytic apoptosis due to viral replication related hypercytopenia. So, having a negative lymphocyte count in the CSF should not shy away from making a diagnosis of encephalitis. RT-PCR assays from CSF samples have been negative in those patients again, and it's hard to find them in majority of patients. So, a negative PCR assay from CSF should not um, exclude COVID-19 encephalitis. So, a proper neurological assessment combined with serological testing plus CSF analysis, including EEG and neuroimaging, will help us in establishing the diagnosis of this type of particular encephalopathy induced by exaggerated innate immune response due to COVID. So I'll go on to discuss few patients. This is a patient detail taken from one of the articles in the web. So it's a 71-year-old SARS-CoV-2 positive female who present with altered mental status. She had been noticed to have seizures from day one of presentation, along with rising CRP. And as the CRP level started going up, the seizures become more and more resistant to control. So she was noted to have prolonged runs of 2 Hz generalized periodic discharges, and her seizures started to get better as the CRP levels started to trend down again. And the diffusion weighted imaging MRI showed numerous punctate foci of diffusion restriction with corresponding ADC changes. So this lady went on to improve with anti-epileptic treatment and steroids, and also immunoglobulin therapy. As her immune response started to stabilize, her seizures and neurological function started to get better. So this is an example of acute necrotizing encephalopathy, which is a post-inflammatory phenomenon. On the top column, you could see patient's MRI showing ventral thalamus hyperintensity on the flare images, along with thalamic and caudate hyperintensities. On the bottom row, you can see multiple white matter changes consistent with the ADAM. So in this slide, we have a patient who has typical um, vascular injury in the watershed areas. We do see surprisingly increased number of watershed area infarcts and hemorrhagic transformations into infarcts, and that often tells us that the large arteries are being affected quite often, which causes hemodynamic changes in the watershed areas. In the bottom row, you could see a patient with COVID showing posterior reversible encephalopathy syndrome with predominant white matter involvement and posterior cortical edema. In this, you could see in the bottom row, you could see M1 cut off on the left side, with also clots sitting in the anterior cerebral arteries, blocking its flow. So this patient has ACA territory infarcts and went on to improve with usual treatment with post-stroke antiplatelets and anticoagulants. So apart from strokes, there are patients who develop necrotizing encephalitis along with strokes. In this, the angiogram on the top right does not show any major vascular occlusion, but the whole of the right MCA territory is severely affected with a lot of edema and ischemia. And the MRI shows a gyral inflammatory pattern with a lot of microbleeds, which is consistent with neuro inflammation. Unfortunately, this lady did not improve, and she died. And her brain biopsy confirmed the presence of SARS-CoV-2 virus in the brain tissue. We have a lot of patients who come with large artery thrombus. There is a sudden cutoff of basilar flow in this patient's DSA, and which was successfully treated with endovascular technique, and the post-treatment showed a small infarct in cerebellum and brainstem. And in this, in the bottom row, you could see vascular occlusions in the MCA vessels, leading on to bilateral MCA infarcts. I'll show a video, not a video, a picture of a patient who we just treated last week, who presented with acute right-sided weakness. And the CT angio on arrival showed a very large thrombus in the left common carotid artery, which is a very unusual place for a 38-year-old fit and well gentleman. And this gentleman has had mild diabetes, but of late has not been controlling it properly. So he did not have any direct COVID-related complaints. His COVID IgG test is pending, and on the top right you can see the clot's extent in the common carotid, and in the bottom right you can see the clot is occluding almost half of the lumen. So he also had a tight left MCA stenosis, which is again unusual. So he had a carotid stenting with good flow in the left carotid system. We did not touch the left MCA stenosis because it was very long segment stenosis, and we didn't want to cause more damage during the intervention. So the next day, MRI confirmed a left MCA territory infarct. But luckily, he has recovered his aphasia and is slowly starting to stand and take few steps with improving lung function. So I'm hopeful that his right arm function will gradually recover in the next 2 to 3 months' time. So this is again one of our patients in Kaveri who came to us with acute right-sided weakness, and the top left MRI picture shows bilateral cerebral peduncle hyperintensities on the MRI, which is again seen on the top right, and unfortunately the whole of the basilar was invisible on the scan. But the patient presented to us very late, and he is currently ventilated and intubated. And a repeat CT scan showed recanalization, spontaneous recanalization of the basilar artery, and we are hoping that he may slowly recover. So apart from this cerebral peduncle hyperintensities, his pons and medulla are intact. He may end up with a significant quadriparesis, and we are going to probably do a tracheostomy soon and try and get him to neurorehabilitation. So this is a study from the Mount Sinai Hospital in New York, where they had seen a lot of evolving large vessel occlusive strokes in the last 3 weeks of COVID outbreak. And you can see in this graph, on a month-to-month average, they see about 20-odd large vessel strokes, but since the outbreak of COVID-19, the number has almost doubled. So we have been trying to reach out to the public not to avoid routine neurological or any medical complaints for the fear of coronavirus, and promptly seek medical advice. But unfortunately, across the globe, there's a study from Hong Kong which shows that the usual door-to-needle time has dramatically increased post-COVID. So onset to door time and door to needle time has dramatically altered. So a lot of patients are coming to the front door very late, so they miss out on very effective treatments in acute stroke, which are IV thrombolysis and endovascular thrombectomies, and go on to become severely disabled and even lose their lives, which could have been easily prevented if they had come quite promptly. So this is a very good information from the Global Stroke Registry from especially relating to COVID patients. So on the top bar of the ordinal scale, you can see the black bars are those who have died on a routine non-pandemic time frame due to stroke, which has increased almost threefold during the COVID-19 pandemic period. And you can see in the blue bars the number of patients who present with medium to large strokes, which is in line with the NHS score, is proportionately higher. So, how do we manage strokes in COVID patients? So, this is a very complex slide which shows the multiple pathways through which coagulation, fibrinolysis, and inflammatory complementary mechanisms can act. So, do we think that simple anticoagulation, low molecular weight heparin, or oral anticoagulation would be enough? So, I think we should be blocking at multiple clotting points, coagulation points, to achieve a successful end. And there are a lot of studies that are ongoing, and this is a algorithm from the International Society of Thrombosis and Hemostasis, which kind of tells what to do in the scenario with coagulopathy. So it clearly helps us to know if the DML level is raised or not markedly raised, and go through the flow chart and see how we can treat patients. So the general consensus is that we should start prophylactic dose low molecular weight heparin, and the dose doesn't have to be always a low molecular prophylactic dose. It has to be increased in those with a very high D dimer and those who have a low platelet count, especially if they're non-bleeding. And we should try to keep the platelet count above 25 with platelet transfusion if necessary, and sometimes treat simultaneously with low molecular weight heparin and antiplatelets, or antiplatelets plus oral neuroanticoagulants. So monitoring of PT, APTT, D-dimer, platelets, fibrinogen, CRP, and ferritin can help us to pick out patients who are at risk of getting thromboembolic complications, and also in the long term monitoring post-COVID and initiating treatments. It is advisable to start prophylactic anticoagulation with low molecular heparin in all patients with COVID-19, and the dose has to be higher in those with high D-dimer or in those who have confirmed thromboembolism. So we should be watchful for paradoxical embolism. Elderly and anyone with usual vascular risk factor has to be screened meticulously because they are the ones who are more prone for coagulopathy. And what is the duration of the oral anticoagulation post-COVID is still unknown, but in our center we treat with oral anticoagulation for at least a month with aspirin. Anti-inflammatory therapies can reduce the inflammatory process and reduce the coagulopathic burden. Remdesivir antiviral therapy is known to reduce the hospital stay of patients, so anyone with thromboembolic phenomenon should be offered antiviral therapy. Thrombolytic therapy is routinely done in those patients with confirmed thromboembolism, and there are studies which have gone to recommend that even those with ARDS are being trialed with thrombolysis, because we all know in those with ARDS there are multiple microthrombi in the lung, and they are hoping to see better results in those patients. Endovascular therapy is a lifesaver in many situations and should be promptly offered. So yes, in this COVID pandemic, we have encountered a lot of stroke patients, especially large artery stroke patients in a younger age group. And in the post-COVID scenario, we are hoping to see quite a lot of patients with cranial palsies, like facial palsy, Bell's palsy. I have seen a lot of Bell's palsy the last 6 months than in my entire career. And we probably would end up seeing a lot of patients with seizures, headaches, and other complications due to vasculopathies. So let us all be informed and help all our patients in this very difficult times. Thank you.